Hey everybody, Dr. Brian Mann from Texas A&M University. Just wanting to go over a little bit of anatomy with you. With our joint thing that we're doing, let's talk about the shoulder today. So the shoulder, what does it do? Well, it's got 3 degrees of freedom, so it does a lot. So it will flex and extend the arm. So that's coming up in front and coming, so as if you're doing like a dumbbell front raise. That would be the flexion, and the lowering of the arm would be extension. It's like, wait a second, you're lowering, so it's the opposite of flexion. Yeah, I mean that you're moving through extension, but using your flexors. But that's for a different topic for a different day. So I'll shut up. Abduction and adduction of the arm. The abduction is like doing a lateral raise, and the adduction is returning it. Internal external rotation. Well, if you've done internal and external rotation before, it doesn't matter the position that you're in. You can do it for multiple different ones. You know what those are. Then circumduction. The circumduction is one that might not make sense to you. Circumduction is the combination of multiple planes to look like you've got, that you can do a 360 degree range of motion at a joint there. It looks like the way that your arm can do a whole circle. Well, it's not doing a full circle so much. It's just using the multiple planes to make it look as such. So that's another function of it. Now, we also have got what would be called horizontal or transverse of like AB and adduction. So that would be like a pec fly or a reverse pec fly. Now, the shoulder is also called the glenohumeral joint. Why? Well, the glenoid fossa sits on the scapula, and the head of the humerus is what sits into it. It is a ball and socket joint. So a ball and socket obviously means it has great range of motion, but the shoulder joint has really, really poor stability. You see, the glenoid fossa is about the depth of golf tee, really. So we don't, it doesn't create a tremendous amount of stability, which is why you always hear about shoulder injuries. But if we think about another ball and socket joint, the hip, you never really hear of dislocations of the hip. But you hear about shoulder dislocations all the time, and the lack of bony stability is a great reason why. So if we look at the bones of the shoulder, okay, well, let's look here. We see that, as I mentioned before, we've got the humeral head, okay, right there, nice and green. This little bone up here, this little S-shaped bone that can rotate and which causes it to flip up and flip down, giving a lot more range of motion, is the clavicle. And then we see the scapula bone. Okay, and the scapula bone, also in green, we've got our glenoid fossa. Now, this little sucker here coming out to say hello, that's called the coracoid process. Now, it's a pretty interesting, at least to me, anterior projection off the scapula. And, if you think about the scapula, it's on the back of your body, but you can actually feel this part from the front. Just a little, I don't know if you would say party trick or whatever, but if you find the end of your clavicle, right, into your collarbone, out at the acromion. Now you go down an inch and in an inch, and you'll feel this thing that kind of feels like a pen cap. That is your coracoid process. And if your pec minor is tight, like most people's are, or the short head of your bicep is tight, like most people's are, it will be pretty painful to go ahead and touch that sucker. So, we whenever we're thinking about those things, we need to pay attention. But, it's just a cool little party trick. I always thought it was cool to see that coracoid process there. Now, the muscles. What muscles cause these actions? Well, flexion. It's going to be the pec major, but really just the clavicular portion of that, the deltoid, the anterior portion, the coracobrachialis. Now, remember that the anatomists are greatly interesting people. You remember that coracoid process that we just talked about? Well, it comes from, the muscle goes from there down to the brachial region, so over on the humerus. So it'll help with flexion as well. And also the long head of the biceps brachii. It's like, how does it do that? Well, dude, remember the long head of the biceps brachii actually starts at the supraglenoid tubercle. So that's how it does that. Now for extension, we've got some muscles on the back side. Latissimus dorsi, teres major, the deltoid, the posterior side of it's going to do quite a bit, the posterior delt head. The long head of the triceps brachii is going to do some extension, and a little bit, especially down at the bottom, whenever we're talking about the major part of the pec major, the larger part, not the clavicular part, but the sternal head. Now, if we look at adduction, well, it's just what we would think. Coracobrachialis, again. It's like, how is it doing that? Well, normally it's just for a little change of the hand. Latissimus dorsi, teres major, and then the pec major. Now, if we look at abduction, we have our supraspinatus and our deltoid. Now, if we look at a lot of the muscles that we just talked about, here we see that we've got the clavicular head of the pec major and the sternal head, just as we had separated those two things out. Now, we don't see the coracobrachialis. Why? Well, because it's deep to the pec major, and it's also deep to the anterior delt. So it'd be pretty tough to see that here. Now, let's see, what else should we look at? Well, we see the long head of the biceps muscle. It's coming up here on the lateral aspect. Now, the short head is coming up and inserting into that coracoid process, like we had mentioned. We can see a little bit of the lat coming out the side, and it's getting ready to come in and insert into this bicipital groove down here. And I think that's most of the muscles that we have just talked about. Well, we talked about the deltoid, right? Well, deltoid's right here. You can see this part that you can see coming in from the front. Well, most of that's the anterior delt. And then as we're getting into the straight down portion over here, that's medial. Now let's talk about our muscles of internal rotation. So our muscles of internal rotation are ones that cause our arm to turn in. Well, we could see that we're going to have the subscapularis as a prominent internal rotator. Teres major as well, and the latissimus dorsi and the pec majors. Like, we don't think of those as internal rotators, but they, due to their angle, their line of pull, they absolutely do internally rotate the head of the humerus. And then the deltoid, it's going to cause it a little bit because of all of the pennation angles that the delt happens to have, which is why it is able to do internal and external, because we've got it coming down from every which way, as my grandmother used to say. For external rotation, we have the teres minor and the infraspinatus. Now, the teres minor and infraspinatus, well, the infraspinatus definitely is sitting on the posterior aspect of the scapula, and the teres minor is down near that inferior angle. So as they're pulling with their location of the insertion on the back side of the arm, that's going to cause an external rotation. And then we have got just our rotator cuff, which I've always learned as sits. Now, we've already talked about some of these muscles. The only one that I believe we haven't talked about right now is the supraspinatus, because that it's the first 10 to 15 degrees of abduction. But we'll talk about that in a different exercise, or a different video on the lateral raise exercise. So the sits muscles, the supraspinatus, infraspinatus, teres minor, and subscapularis, that's just the way that I always learned, even as an undergrad, to be able to remember, what does this do? Now, let's take a look at these. Now, the supraspinatus, again, I mentioned how the anatomists are incredibly creative. So supraspinatus, superior to the spine of the scapula. We can see how it runs under the acromial arch, inserts in the lateral aspect of the head of the humerus, and it will cause abduction. Now, we could see the subscapularis. Now, this is an anterior view, right? So this muscle is sitting in between the shoulder blade, the scapula, and the rib cage. And then it comes over, and we can see how it gets onto that lesser tubercle right there, and it'll cause that internal rotation. Now, the infraspinatus is inferior to the spine of the scapula. And then we could see the teres minor coming down off of it, getting down here near that inferior angle of the scapula. Now let's talk about some more soft tissue, and let's talk about some of the ligaments. Now, the transverse humeral ligament, it prevents displacement of the tendon of the long head of the biceps brachii. It just keeps that sucker down in. It goes across the bicipital groove to hold that sucker in. Now, the coracohumeral ligament, well, it's going to go from the coracoid process to the humerus, and that's going to strengthen the glenohumeral joint superiorly, meaning that it's not going to let you go up anymore. It limits excessive external rotation and inferior translation of the humerus. It's holding on. You can't go down anymore because there's a ligament there. It's like a guide rope, a support rope. It's just the holding on for dear life if anything else goes weird. Now, the superior glenohumeral ligament, it is formed at the top of the glenohumeral joint, and it prevents inferior translation of the humeral head, particularly during shoulder adduction. So as it's coming down, it's not, so as your arm is coming down, it keeps your glenohumeral joint from moving inferiorly, moving downward. Now, our middle glenohumeral joint stabilizes the anterior capsule and limits external rotation when the arm is abducted. So while ligament, and I guess I should have said this beforehand, after teaching anatomy for so long, I normally do this at the beginning of the year, and I never talk about it again with ligaments. So while ligaments do connect bones to bones, that's not the only thing that they do. They do limit movement. It's like, well, I thought muscles did that. Well, you're absolutely right, but the ligaments are just one more thing to do that. And just in case I didn't say the inferior glenohumeral joint, again, it stabilizes the humeral head when the arm is abducted. So it's providing just more stability in addition to the muscles. So let's look at some of these. Okay, well, if we look at the coracoclavicular ligaments, these, which I don't believe I had mentioned, they actually, instead of being glenohumeral ligaments, these actually are what keep your clavicle down, and they cause the posterior rotation so that this sucker flips up and you get a lot more range of motion. So we can see that we've also got those coracoacromial and coracohumeral ligaments. We can see the transverse humeral ligament, and then the superior, middle, and inferior glenohumeral ligaments that we had just mentioned. So these are down deep, creating some capsular stability. Now, now speaking of capsular, the joint capsule. Now, the joint capsule, this is just a synovial capsule. So it's a loose fibrous capsule lined with synovial membrane. This is what provides stability and allows for a wide range of motion. Now, we also have a labrum. Now, the labrum is a cartilage that goes around the rim of the joint. So it deepens the fossa. Now, by deepening the fossa, we're going to provide more stability. Not only that, but the labrum also is a attachment site for ligaments and tendons. So the muscle inserts into the labrum via the tendon. It's like which ones? Well, an example of which would be the long head of the biceps inserting into the supraglenoid tubercle and labrum. Now, if we look at here, let's keep going down. We have the bursa. Now, the bursa are synovial fluid-filled sacs. They reduce friction. They reduce impact. They're nice little bumpers to have, so to speak, for your joint. And then with our tendons, we have our rotator cuff tendons, biceps tendons, pectoralis major and minor tendons, coracobrachialis. Dude, if we got a muscle insert and we got a tendon, all right, let's just be honest. So we look here at this side cutaway, and you can see the glenoid fossa and how it's deepened out by the labrum. Cavity fossa, same thing, tomato. You can see how this little structure right here coming in, that's the long head of the biceps. And it's inserting into that supraglenoid tubercle in the labrum. Now we could see we've got a cutaway of the muscles, but here we also see we've got this cutaway of the subacromial bursa, meaning it is below the acromion, keeping the head of the humerus from hitting that, reducing friction. We can also see the subtendinous bursa of the subscapularis. So this is going below the subscapularis, to allow for the muscles to, the tendon to slide. So here we can just see some of those supporting structures here. Common injuries. Well, of course, for the shoulder joint, it is super common. Rotator cuff tears. Man, I don't know if anybody knows somebody that hasn't had a rotator cuff injury. And the rotator cuff, we should probably do something about it specifically anatomically or coming up in the coming weeks. But the rotator cuff is something that is used to stabilize and compress the joint. Well, it's like, well, why would we have tears of that? Well, we got the most unstable joint that's possible. So, of course, when we're trying to protect that, a muscle might give. Dislocation and subluxation. What these are two sides of the same coin. The subluxation is kind of like a partial dislocation. It pops out. It could cause some disruption, but then the head of the humerus sits back into the glenoid fossa. The difference with the dislocation is that it usually doesn't sit back in there. The structures are more torn, so it doesn't go back into place. Shoulder impingement syndrome. Impingement is a lot like it sounds. It just means something gets pinched. So by something getting pinched, there's going to be some sort of injury. Now, what is an example of it? Well, the supraspinatus. Let's go back, and we can see how that supraspinatus fits right through that arch of the acromion. Well, there's not a lot of room there, is there? And we can see that supraspinatus. Well, if the head of the humerus comes up, it's going to be pinching that supraspinatus between the acromion and the head of the humerus. That is shoulder impingement. It's like, why is it occurring? Well, because the humerus isn't sitting in the place it's supposed to within the glenoid fossa, or that there's some improper muscle strength causing an improper movement pattern, which allows that to occur. Labral tears. The labrum can tear anywhere. Now, most commonly, actually, there isn't a most common, to be completely honest with you, because it varies by sport. You'll hear of something called a slap tear, superior labrum anterior posterior, which is basically the head of the biceps. Long head of the biceps is withdrawn, pulls out, and it takes some of the labrum, the top of the labrum with it. We can see a lot of posterior tears. That often occurs with offensive linemen as they are receiving the defensive lineman coming into them. So those posterior stresses rip that sucker out the back. But you can have those tears go anywhere. And then we could see, hey, AC joint sprain, acromial clavicular joint sprain. So this ligament here gets torn. Okay, it has got 3 degrees, as any ligament sprain does. The first and the second, or the second's the most painful usually. The third doesn't hurt because the nerve gets torn with it, because that's a complete tear. Whenever that tear happens, whenever that tear happens, the acromion and clavicle separate, and then the acromion usually sticks up, and it looks pretty funny. The surgery and repair for it's kind of tough, but it is what it is. Okay, guys. Shoulder joint maintenance. If you want to have healthy shoulders, first thing you can do is strengthen the rotator cuff. Now, I don't mean just the simple internal and external rotation. There's a lot more that can go into it. And again, it makes me realize that, hey, we probably should do a video just on the rotator cuff. But we could fix our posture. Now, fixing our posture isn't working on the shoulder muscles, but on the scapular muscles. So the muscles that would retract the shoulder blades. So that would be our rhomboids, middle traps, depressing the shoulder blades like our lower trap. So our muscles for posture are not our muscles for movement. Mobility. Well, shoot, we could do sleeper stretches, the wall slide, sometimes called wall angels, stretching the pecs, stretch the lats, make sure that our thoracic spine is moving. We want to avoid high risk lifts with poor form. So, what would a high risk lift be? Well, maybe something like a snatch or a jerk that are going to be very, very technical. If we catch those in poor positions, or maybe we're trying to do this from a very, very kyphotic posture, probably not going to be a good idea. And then dynamic warm-ups. It's always a good idea to make sure that everything is moving and functioning as well as possible as you are doing the movements. Hey guys, if you like information like this, please, please, please join us in Aggie Land. Hey, we've got clinics, we've got a bachelor's program, we've got a master's program related to strength and conditioning and performance physiology. We'd love to see you down here in College Station. It's a very, very special place. Again, we also have clinics, and we'll have other things we do to support the profession. That's it for this